सभी को मेरा नमस्कार। विश्व आयुर्वेद परिषद की ओर से आयोजित इस अनवरत व्याख्यान माला में मैं आप सभी का हार्दिक स्वागत करती हूँ और सभी प्रतिभागियों का भी। मैं क्षमा प्रार्थी हूँ, थोड़ा सा कुछ इंटरनेट में कुछ हो रहा तो दिक्कत आ गई थी। मैं फिर से सभी का हार्दिक स्वागत करती हूँ और आज के व्याख्यान की शुरुआत करने से पहले मैं आज के स्पीकर का परिचय आप सभी के सामने रखना चाहूंगी। आज का व्याख्यान बहुत ही ज्यादा इंटरेस्टिंग है और मुझे लगता है कि सभी को बहुत अच्छा पसंद आएगा कि हम वर्तमान समय में चिकित्सा बढ़िया से बढ़िया करने के लिए जिन बातों का हम ध्यान रखना चाहते हैं, चाहे वो आयुर्वेद की दृष्टि हो, जहाँ रक्त व स्रोतस का मूल यकृत और प्लीहा बताया है, तो आज यकृत के ही LFT लीवर फंक्शन टेस्ट के ऊपर हमारा आज का लेक्चर है और वो बहुत ही अच्छा रहेगा, जो हमें क्लिनिकली भी बहुत अच्छी तरीके से साउंड होने के लिए मदद करेगा। तो सबसे पहले मैं आज के स्पीकर का आप सभी के सामने परिचय रखना चाहूंगी। आज के हमारे स्पीकर है डॉक्टर मधुसूदन जी, डॉक्टर मधुसूदन बी जी। आप है हेड ऑफ द डिपार्टमेंट एंड एसोसिएट प्रोफेसर एट डिपार्टमेंट ऑफ द पीजी स्टडीज इन रोग निदान एंड विकृति विज्ञान JSS आयुर्वेदा मेडिकल कॉलेज एंड हॉस्पिटल मैसूरू कर्नाटक में अभी वर्तमान समय में आप कार्यरत है। और आपका जो परिचय मैं सबके सामने, जो पार्टिसिपेंट्स के सामने रखना चाह रही हूँ कि डॉक्टर साहब का एज अ ग्रेजुएट उन्होंने किया है मैसूरू कर्नाटका कॉलेज गवर्नमेंट आयुर्वेद मेडिकल कॉलेज, और वो यूजी के टॉपर रहे हैं ग्रेजुएशन में। आपने अपनी पीजी गवर्नमेंट आयुर्वेद मेडिकल कॉलेज बेंगलुरु कर्नाटका से रोग निदान एवं विकृति विज्ञान, जैसे मैंने बताया, जहां आप अभी हेड ऑफ द डिपार्टमेंट की भूमिका निभा रहे हैं, उसमें आपने पूर्ण किया है। और वर्तमान समय में आप पीएचडी को परस्यू कर रहे हैं अंडर राजीव गांधी यूनिवर्सिटी ऑफ द हेल्थ साइंसेज बेंगलोर कर्नाटका से कर रहे हैं। इसके सिवाय आपने एमएससी इन माइक्रोबायोलॉजी फ्रॉम कर्नाटका स्टेट ओपन यूनिवर्सिटी से आपने पूरा किया है। आपने बहुत सारे पीजी एंड पीएचडी स्कॉलर्स को एमडी डिसर्टेशन के लिए आपने गाइड किया हुआ है और को गाइड भी किया हुआ है। आपकी हमेशा मेंटरिंग यूजी मेडिकल स्टूडेंट्स के लिए, रेसिडेंट्स के लिए बहुत ज़्यादा पथ प्रदर्शक रहती है और नेक्स्ट जनरेशन के हैंड टू हैंड ट्रेनिंग के लिए भी आप अपने स्टूडेंट्स के बीच में बहुत ज़्यादा पॉपुलर है। और आपका 15 साल से ज़्यादा का क्लिनिकल एक्सपीरियंस है, जिसमें आपने अनेक पीयर रिव्यूड जर्नल्स, आर्टिकल्स, नेशनल और इंटरनेशनल जर्नल्स में आपके प्रकाशित है। और जो सबसे बढ़िया बात मुझे उसमें लगी कि आपका एक आयुष मिनिस्ट्री में एक रिसर्च प्रोजेक्ट सैंक्शन हुआ है। तो सबसे पहले तो मैं जीरो गिन रही थी कि इसको मैं कैसे पढ़ूंगी। तो 60 करोड़ का एक प्रोजेक्ट, जो रिसर्च प्रोजेक्ट्स, एक्स्ट्रा म्यूरल रिसर्च प्रोजेक्ट्स आपने
Madam, it
किया
is
हुआ
60
है।
lakhs.
60 लाख है?
Yes, madam.
नहीं, उसमें मैंने जीरो गिने। 5 6 7 8 जीरो है सिक्स के साथ। तो मैंने इंटरनेट पे देखा, मैंने कहा इसको कितना बोलेंगे, तो इंटरनेट ने बताया कि 60 करोड़ बोलेंगे।
Sorry, madam, it is 60 lakhs. Sorry.
अच्छा, 60 लाख है, ओके ओके, ठीक। तो सॉरी, वो प्रिंटिंग मिस्टेक है, तो इस वजह से थोड़ा सा ऐसे रहा। तो आपके टू कंप्लीटेड रिसर्च प्रोजेक्ट्स एंड यू हैव कंट्रीब्यूटेड so many एडवांसमेंट इन द मेडिकल साइंस एंड क्लिनिकल प्रैक्टिस। और करंटली जो मैंने मिनिस्ट्री ऑफ आयुष से ये प्रोजेक्ट बताया वो भी आपका सैंक्शन है और इसके ऊपर भी आप काम कर रहे हैं। और सबसे बड़ी बात जो इसमें लगा था कि जो पेशेंट साइकोलॉजी, ह्यूमन साइकोलॉजी को लेके आपका जो एमडी के अंदर काउंसलिंग एंड साइकोथेरापी, उसमें आपका विशेष इंटरेस्ट है और इसके कारण यू आर वेरी पैशनेट लर्नर। और बहुत ज्यादा मीन्स मुझे लगता था कि साइकोलॉजी किसी की समझना, चाहे पेशेंट की एज ए डॉक्टर भी समझना, है ना, ये भी एक बहुत अच्छा पॉइंट है कि जिससे हमें चिकित्सा के क्षेत्र में भी बहुत सारी सफलता मिल जाती है। तो ऐसे विद्वान स्पीकर को नो डाउट आपके पास विश्व आयुर्वेद परिषद का भी कार्यभार है डॉक्टर साहब, है ना? हेलो डॉक्टर
हाँ
डॉक्टर
मैडम, हाँ मैडम।
हाँ, क्योंकि मुझे इसमें मिला नहीं, तो बस वो भी लास्ट में ही मुझे ध्यान आया। तो विश्व आयुर्वेद परिषद के आप कार्यकर्ता भी हैं, अधिकारी भी हैं। तो ऐसे व्यक्ति का मैं अपने ही आपके ही अपने प्लेटफॉर्म पे स्वागत करती हूँ। और आज के व्याख्यान के लिए मैं आपको आमंत्रित करती हूँ। ओवर टू यू डॉक्टर मधुसूदन जी।
Thank you, madam. Thank you for the generous introduction. I ask sorry from all of you that my Hindi is not so good, so I would like to continue my talk in English itself. Madam, I am unable to share my screen.
अच्छा, मैं करती हूँ एक बार, है ना, वो कुछ
Please
पता
give
नहीं
me
क्यों
permission,
इसकी, है
madam.
ना, कुछ वो लिंक लेफ्ट हो गए थे, ऐसा कुछ रहा। मैं करती हूँ डॉक्टर साहब। नाउ यू कैन शेयर डॉक्टर साहब।
Yes, ma'am. Yes, ma'am. I hope it is visible now, madam.
जी डॉक्टर साहब, विजिबल, यस।
Uh, are the slides changing now?
हाँ जी, हाँ जी, चेंज हो रही है जी। ओके।
Thank you. Let me first thank Madam for giving me this opportunity and her tireless job, which has made things possible to continue this for a very long time. Uh, uh, Hats off to you, Madam, for all the efforts, pain you're taking in making these things happen. I know the effort behind all this because when we used to conduct, maybe people may think it is online, but there are a lot of efforts behind these. Uh, Hats off to you, madam, and thank you for inviting me and giving me a platform, giving me time to share my views and whatever is being practiced, whatever small I have learned, I would like to share with you. With pranams to all my teachers and Almighty. So let me start by asking. We commonly LFT has now become a almost like a routine investigation in our practice. So let us know much more about LFT, what, why, when, and all the questions about LFT. Let me try to give you all an answer. Acharya Charaka says, we all know this. Rogamado pariksheta tato anantaram aushadam tatah karma bhishak paschat jnana purvam samacharet. Investigations, let us consider investigations are as a mode of Roga Pariksha. Moving on, why do we need investigations? Are they needed? Let it be any investigation, not only LFT, maybe starting from CBC to a complicated biomarker. Do we need investigations? Aren't the clinical examination enough? Is not the history taking give us enough information for disease diagnosis? Investigations are needed for confirmatory diagnosis. Whatever we have made in the clinics, whatever we have made in the examination, that is being confirmed by the investigations done. It is important for us to understand the inclusion and exclusion of multiple diseases which we consider for differential diagnosis. Investigations are also important in monitoring the disease and also the treatment. So how can we understand the treatment what you have given is making the person feel better? There might be subjective improvements or not, but if we have an objective parameter to analyze them, so the best, one of the best would be the investigations of different genres, and to have a baseline establishment prior to treatment initiation. So considering all these, investigations are considered quite important enough, especially these days, in diagnosis, in monitoring, and also in baseline establishment. So before I jump into the proper topic of LFT, let me give you few case scenario why we need to understand LFT, because I am sure I was speaking with madam. Madam said that the PGs and clinicians will be the audience or listeners or participants. So I thought of, let us keep some practical case scenario. So why to understand LFT? Do we get all reports the same, or do all presentations with ICTRUS are same? So how to understand? So let me give you a few case scenario. So now we have a patient who is presenting with fever, pain abdomen, nausea, vomiting, loss of appetite, anorexia, high colored urine. He has a history of traveling. So on examination, the findings are tender hepatomegaly and he is having significant icterus. So this is case scenario 1. Case scenario 2, patient presenting with abdominal distension, nausea, vomiting, loss of appetite, anorexia, high colored urine with swollen legs and blood in stools and vomitus. Both are presenting with icterus, both are presenting with pain abdomen, but here there is difference in the case scenario. This case is also presenting with ascites with enlarged veins on the abdomen. Here is a patient who is presenting with greasy pale stools, severe generalized itching, anorexia, loss of appetite, and all that. Patient has a past history of gallstones, multiple gallstones. So on examination, we can find there is significant icterus along with scratch marks on the different parts of the body. And one more case presenting with severe tiredness, weight loss, abdominal pain, and all that, wherein the patient is mildly itching, significantly paler, and the patient is having splenomegaly. On examination, we can find out these. We can see in all these cases there is icterus, and as soon as we get a case, maybe in history or on examination, when we see the patient is presenting with icterus or history of yellowish discoloration, the very first thing which come to our mind is, let me write a LFT investigation. So let us try to understand it much better. I have also posted few investigation reports, so that let us try to go deeper into LFT. Here is, you can see a case, patient presenting with icterus. When I got a LFT done, the values went like this. You can see the total bilirubin is 6, the direct bilirubin is 5. So this is a typical case of direct hyperbilirubinemia, wherein you can see the SGOT, SGPT are significantly raised. It is, when the upper limit we commonly say, easy to remember, is 40. So it is more than 4,000 SGPT. SGOT is, it's almost touching 3,000 mark. Is quite high. Along with that, ALP, GGT, they're all raised, but there is no significant amount of rise. Wherein we can also see the protein is quite normal here. We have a significant rise in OTPT, which we commonly say in lab language, whereas there is rise in bilirubin levels, normal levels of protein. So what is this case? There is another case presenting with total bilirubin 4, direct bilirubin 0.2, indirect bilirubin 4.3, whereas the previous case it was direct bilirubin which is on a higher side. Here it is indirect bilirubin which is on a higher side, and if you can see, all other values are almost normal, except there is small reduction in the globulin, which is not so important finding. Whereas you can see down below, the hemoglobin is 6.7. we can see there is impairment in the values we have got. There's an additional test which also says the hemoglobin is 6.7. LFT changes are there. Even in the previous case report, LFT changes were there. So are these two reports the same? There's one more case which says total bilirubin is 8.7, direct bilirubin is 7.1. And we have OTPT which are nearing to thousands, and we have ALP and GGT which are slightly raised, but we have all the protein values are normal. And we have another report which says significant rise in bilirubin with direct bilirubin, low serum albumin, high serum globulin, mark a small amount of rise in AST, ALT, that is SGOT, SGPT, and a significant rise in ALP also along with GGT. We have 4 different case scenarios. I had shown you 4 different case scenarios, and we have 4 different LFT reports. Do all these are same? How to approach this? Let us understand. So let me introduce you all to LFT. As we all know, liver is the major organ of homeostatic maintenance. How is this possible? Because it has a good number of functions it does. It caters a multitude of functions. So to understand all these functional discrepancies, to all these functions which have become hampered, one test will not be enough. Since it's quite a big organ, it's a biggest gland, and it has got numerous functions to do. So can one test say all these things are normal or not? So it is not possible. So we have a group of tests. We have a battery of tests which are clubbed together to form what is called as liver function tests. And why we have to understand is because liver disease accounts to approximately 2 million deaths per year worldwide. Moving on, let me take you all through a brief anatomy of liver so that we can understand about these later in applicability. We all know liver has got dual blood supply, one from the portal vein and the other from the hepatic artery. Branches of hepatic artery become hepatic arteriole, and we have the portal venule. All these two have a unidirectional flow where the venous blood and the arterial blood mix, and they end up in the central vein, which drains later into the inferior vena cava. And the bile moves in the opposite way. Bile is moving in the opposite way. This is getting connected into the bile duct, goes out into the extrahepatic biliary apparatus, gets stored in the bladder, and it is released whenever required. So in this is what is called as the hepatic sinusoid. In this we have the portal vein, the hepatic arteriole, and we have cells surrounding all these. These are the heroes of the liver, the hepatocytes. And in between hepatocytes we have these special cells called as Kupffer cells, which are important in maintaining the immune system of the liver. And we have these stellate cells, which are again a part of immune system. These stellate cells are important in terms of cirrhosis of liver. Where does the cirrhosis, where does the fibrosis start with? Is this stellate cell is the main point where the point of cirrhosis starts from. Moving on, to make it more easier, we have in a 3D like diagram, we have the liver anatomy looks like this, wherein we have the dual supply parts, they mix up together and they end up in draining into the central vein, and wherein we have the bile duct, wherein the bile moves in the opposite direction and gets collected here. And when you cut open this, we have this section, we have the sinusoid, within which we have the Kupffer cell, we have the stellate cell, and again a dendritic cell, which is an immune cell of the liver. This is how a hepatocyte looks like. You can see this is the hepatic sinusoid, and this is the bile canaliculus, and this is a lot of mitochondria within, which does multitude of functions. The liver is capable of converting a lot of things, so it requires a lot of energy, and it does a lot of functions. So it has got all the required cell organelles of a cell. So moving on, what are the functions of liver? I have tried to uh, make them as small as possible. Metabolic functions related to carbohydrate, protein, fat, and also of bilirubin. We all know the conjugation of bilirubin happens in liver, so that's a major metabolic function in liver. Storage, starting from iron, starting from vitamins, starting from glucose in the form of its storage. Liver stores n number of things in it, I can say. It synthesizes numerous proteins, it synthesizes numerous complex molecules within it, and so we have such a complex cell also. Excretory, we know liver is a major detoxifying organ in our body, and it has a good list of excretory things from it, and the major one is the bile. Along with that, it also excretes many unwanted things, and also it makes them more acceptable for the body. That is what is the detoxification. Next, we know the most toxic substance present in our body, it is ammonia. Ammonia is converted into urea by the Krebs cycle in liver. This is why whenever patient presents with end stage hepatic disease, we get to see the cases with hepatic encephalopathy. Liver also does hemolysis. Liver is a part of the system wherein hemolysis happens as well as hemopoiesis happens. Liver has a function of phagocytosis. There are cells present in the liver which are dedicated to phagocytosis, which are dedicated to immune system rather. It also does a lot of other functions also. So how to understand cases? I've tried to make it more, let me use the word simpler rather than, and also more of clinical view. So what do we understand in this LFT case in cases of, in terms of history? Age, when you get a case of early adulthood or a school going kid, we usually have to think about the case of icterus presenting to us, maybe a case of infective hepatitis, which usually goes in favor of a hepatitis A. Whereas we have a senior adult who has, wherein there may be a case of history, there may be a case of travel also. In them also, hepatitis A can happen. But as the age increases, we have to think of other issues also. And to think of children presenting with icterus, we may have to think of genetic diseases which end up in icterus. Rural Maharashtra, Shimla, Kerala, they are endemic to specific types of hepatitis. Travel history to endemic areas, then we have to be specific of if the patient has a history of travel to any particular endemic area, then we have to think of that particular disease. As I said before 1990, if the patient has underwent blood transfusions, because before 1990 there was no strict screening of the different hepatitis viruses. That is why if the patient has a history of IV or intranasal drug abuse, then we have to think of hepatitis B infection. Sexual practices, anal sexual practice, unprotected sex, multiple sex partners, or sexual activity with infected, then we have to think of the STIs. One among them is hepatitis B virus. If there is a family history, or if there are family members suffering from similar complaints, then we have to think of some infective hepatitis which spreads through fecal-oral route. Occupational, we are all doctors. We all have higher susceptibility of getting infected with hepatitis or hepatitis B because of needle prick or because of exposure to patients. People who are working in dialysis units, surgeons, people who have the habit of body piercing, shared razors, shared toothbrush. In all these patients, when present to us with icterus, we have to think about an infection which spreads through these modes, maybe a hepatitis B. Ingestion of raw shellfish. This is in Western countries where people have the habit of ingesting shellfish in raw form. Then we have to think of a bacterial infection which ends up with icterus. Medications history, we have to think of um, the toxic hepatitis, over the counter drugs, vitamins, because hypervitaminosis can also give features of icterus. Alcohol history is quite common in, as I said, in senior age group, wherein people present to us with jaundice, people present to us with edema, people present to us with chronic hepatitis. They all have, many of them have past history of alcohol. History of other diseases, multiple systemic chronic diseases can end up in hepatic issues, maybe because of the disease itself or maybe because of the treatment protocol which is being followed. Reduced urine output is a significant finding which indicates multiple system involvement. Altered consciousness, confusion states, as I said, may point us towards the hepatic encephalopathy. Contact with pet animals is a significant finding in history, which tell us about which tell us about question mark leptospira, which is quite different from what we routinely find cases of hepatitis, different kinds of hepatitis. Moving on, once we finish clinical examination, once we finish the history taking, we all proceed towards the clinical examination, wherein we try to ascertain, we try to look for pallor, we try to look for icterus in the conjunctiva, icterus in the sclera, rather icterus in skin, icterus in different mucosa. If the patient is wasted, if the patient has lost weight, if the patient has maintained the same weight, or if the patient has gained weight because of edema, all these matter. There are excoriations in skin, which are the scratch marks, which indicate a obstructive one, needle tracks, petechiae, which say about the chronic hepatitis, which is an important finding in chronic jaundice. Breathlessness indicates edema in different parts of the body, collection of fluid in different sacs, muscle weakness, spider angiomata, palmar erythema, gynecomastia, parotid enlargement, Dupuytren's, testicular atrophy, reduced body hair. All these go in favor of a chronic hepatitis, which might be ending up in liver cirrhosis. Hepatosplenomegaly, ascites also again, spider navy, which is similar one, abdominal distension. All these go in favor of cirrhosis ending up with portal hypertension along with ascites. Tender abdomen, dull abdomen. Tender abdomen usually goes in favor of an acute one, whereas dull abdomen indicates a significant amount of fluid collection. Palpable liver, palpable gallbladder, tremors. We know about the different types of involuntary movements which we find in chronic liver disorders. Confused state, disorientation, along with fetor hepaticus. See, these are the different examination findings which I have tried to cover, which present us with different scenario of liver disorders. Moving on, let us move more deeper into LFT. So what is LFT? Is it a proper name? The liver function tests is a proper name for that. Does the LFT, the group of tests under LFT, tell us about the liver function tests? It is actually a misnomer. It does not tell us more about the liver function, whereas it tells us more about the liver diseases. That is why it is commonly called as a misnomer. So it is a battery of tests. It's a group of tests which includes total, direct and indirect bilirubin, OTPT, which are called as the transaminases, along with ALP, GGT, and 5-nucleotidase, along with synthetic functions which tell us about the proteins, which tell us about the plasma proteins, like total proteins, albumin, globulin, and prothrombin. These have, when one part of this is raised, or one group of this is raised, it indicates one different set of diseases. If one is low, the other is high, it indicates another set of diseases. Let us try to understand each one of them. So why we have to learn about, or why we have to understand LFT? It is important to understand, it is important to detect the presence of a liver disease. If all the values come normal, rarely, I'm not saying no, rarely there can be a possibility of a liver disease, because it indicates liver functions. Because liver functions, LFT can be absolutely normal even in cases of liver disorders. That is why it is also called as a misnomer, and there is an explanation for that too. Moving on, to measure the extent or severity of liver disease, we need LFT. Is it a mild case? Is it a moderate case? Is it a severe case? To understand that, we need LFT. What is the pattern of liver abnormality? What is the type of liver disease which is causing icterus, which is causing jaundice? Is it a hepatocellular? Is it a cholestatic jaundice? What kind of disease is this? With LFT, we can also try to identify the specific cause. Why? Is it a case of viral disease? Is it a case of viral hepatitis? Is it a case of obstructive? Is it a case of toxic hepatitis? Is it a case of hemolytic jaundice? We can try to group them, which does this LFT fit into. To investigate possible complications, as in bleeding, as in when we understand the prothrombin time, we can also try to understand about the encephalopathy, to understand also the follow-up in response to treatment. Is there any reduction in the symptoms also, or is there any reduction in values, or there is still the values are getting elevated? So why we have to rather make the patient undergo LFT is to try to understand all these things. So we can group classification, we can group the points under LFT, the tests under LFT into few. So based on the excretory functions of liver, which these are the tests which indicate about the excretory functions of liver, how good the excretory functions of liver are happening. One is bilirubin, the other is bile salt. So it tells us about the enzymes of liver. As I said, AST, ALT, ALP, and GGT, which tell us about the synthetic activity, which tell us about the capacity of production house of liver, which the types of tests are proteins along with prothrombin time. So when you see a report with LFT, if you see AST, ALT is raised, ALP is raised, then you have to think there is some issue which is relating to the enzymes of the liver. Something is causing high, something is causing low, relating to enzymes. When you see that there is rise in bilirubin, then we have to think that the excretory function of liver is what is being to be targeted. When proteins are low, prothrombin time is not normal. We need to understand that the synthetic activity of liver is not happening normally. Moving on, let us try to understand each one of them. Let us try to understand what is bilirubin. What is the major source of bilirubin in our body? It is the RBCs. As the senescent RBCs, as the old RBCs pass through small capillaries of spleen, they become destructed and they release hemoglobin. We know each RBC contains 280 million molecules of hemoglobin, and each have 4 protein chains. Each have 4 chains which have 2 alpha, 2 beta, and each one of them will have 1 hemoglobin component in it. And this hemoglobin is divided into heme and globin. The globin is the protein part, which is further utilized for as an amino acid, or as a protein it is utilized further, whereas the heme, by the action of an enzyme called heme oxygenase, becomes what is called as the biliverdin. Even this heme contains two parts, which is the iron part and the non-iron part. This non-iron porphyrin part is the one which becomes biliverdin. The iron is again utilized, iron is again recycled and utilized at different parts of the body or stored, whereas heme oxygenase acts on the non-iron part and this is converted into biliverdin. Biliverdin is acted upon by another enzyme called biliverdin reductase, which becomes bilirubin. So this bilirubin, which is formed in the spleen, all these are happening in the spleen. This is lipid soluble. This is what is called as the unconjugated bilirubin. This unconjugated bilirubin is transported through the splenic vein and portal vein into the liver. So what happens in liver? In liver, conjugation happens. Thus, in liver, the unconjugated bilirubin conjugates with UDP-GT and forms conjugated bilirubin. This UDP-GT is the enzyme which makes this process of conjugation to happen. Unconjugated bilirubin, indirect bilirubin is converted into direct bilirubin in liver. So this conjugated bilirubin, what is the difference between conjugated and unconjugated bilirubin? Conjugated bilirubin is water soluble, unconjugated bilirubin is water insoluble. I'm sorry, whereas it is lipid soluble. This conjugated bilirubin is then transported to intestines. The bacterial action forms urobilinogen, which becomes, most of it becomes stercobilinogen. It becomes stercobilin and it imparts color to the stools. Why the stools are dark yellowish or brownish in color? It indicates the presence of bilirubin in a different form. Whereas about 18% of it is transported back to liver and about 2% of it becomes urobilinogen, and it is 2% of this urobilinogen is excreted through kidneys through the urine, which is called urinary urobilinogen. I hope this physiology of bilirubin is clear, wherein from RBCs it is on destruction it becomes hemoglobin. The heme is the non-iron part of heme becomes biliverdin, which becomes bilirubin, which is the unconjugated bilirubin, which gets into liver, becomes conjugated, is excreted into intestines, where the bacterial action converts this bilirubin into urobilinogen. Urobilinogen, 80% of them becomes stercobilinogen, which imparts color to the stools, whereas 18% is transported back to liver and about 2% is excreted out of the body through urine. Moving on, what is the normal composition of bile? 1 to 4% is only unconjugated bilirubin, whereas about 99% of it usually will be a conjugated bilirubin. So let us try to understand the hyperbilirubinemia, the pathophysiology behind this jaundice. So what we commonly group them into three. One is the prehepatic or hemolytic, the hepatic, and the posthepatic or the obstructive. So let us try to understand. So if let me say that the spleen is functioning hyper, is destroying more and more RBCs, or there can be a situation where the RBCs itself are abnormal. So what do we find is a case of prehepatic jaundice. There can be a case where conjugation is not happening properly. So that results in a different kind of jaundice. There happens a situation wherein the liver cells are not functioning normally. That will end up in a different case. There happens a case wherein the bile is not being excreted out properly. That will end up in a different kind of jaundice. So these different issues will end up in different clinical features, as well as they will end up in different LFT presentations. So it is the prehepatic jaundice which presents with unconjugated hyperbilirubinemia. It is the hepatic jaundice which presents with mixed hyperbilirubinemia, which usually presents with both conjugated as well as high conjugated as well as high unconjugated. Whereas the posthepatic jaundice which presents dominantly with conjugated hyperbilirubinemia. So if you get a case of high direct bilirubin, think of this may be a case of hepatic or posthepatic jaundice. If you get a case of high indirect bilirubin, Remember this prehepatic jaundice, usually the total bilirubin does not go beyond 5, or few say it as beyond 8, because liver is functioning perfectly normal and it can conjugate and it can excrete, it can metabolize bilirubin, but only things which go beyond the capacity of liver will be getting escaped into the blood, and that is forming unconjugated hyperbilirubinemia. Hence, all cases of prehepatic or hemolytic jaundice usually present with mild jaundice. They do not have very high amounts of bilirubin in blood, and most of that bilirubin will be unconjugated bilirubinemia, as we find in the physiological jaundice of newborn. So moving on, let us try to differentiate conjugated and unconjugated. So what is unconjugated? It is present normally in plasma, whereas conjugated is present normally in bile. How does unconjugated be present in plasma? It is binded with albumin always, whereas conjugated is conjugated to glucuronic acid. Remember, unconjugated is insoluble in water, whereas conjugated is soluble in water. We try to understand it few slides ago. Unconjugated is toxic to tissues. We have heard of kernicterus, which happens in pathological jaundice of newborn. That is because unconjugated bilirubin is protein bound. Unconjugated bilirubin is fat soluble. It can pass through blood-brain barrier and it is found to be toxic to the tissues. Whereas conjugated bilirubin, which is soluble in water, is usually non-toxic to the tissues. Unconjugated bilirubin, the normal values is 0.1 to 0.6, whereas conjugated normal value is 0.1 to 0.4. Mild rise happens usually in case of hemolytic jaundice, whereas the conjugated significant rise in both hepatic as well as obstructive jaundice. What causes unconjugated hyperbilirubinemia is the hypersplenism, hemoglobinopathies, hereditary spherocytosis, the hemolytic disease of newborn, malaria, enzyme deficiency disorders, all these different kinds of issues related to the RBCs. Whereas the conjugated hyperbilirubinemia happens typically things which are related to liver, as it in case of CA, as it in case of cirrhosis, as it is in case of hepatitis, polydocholithiasis, wherein the gallstones which happen may escape from gallbladder and they get stuck in the common bile duct. They end up in forming obstruction. There can be cholestasis, which can be intra or extrahepatic. And one more common finding we get in case of obstructive jaundice, which is not related to the liver per se, is the CA head of pancreas. So these different cases present with conjugated hyperbilirubinemia, whereas issues related to spleen and RBCs present to us with unconjugated hyperbilirubinemia. Moving on, as I said, usually it is related to the RBCs, and here in conjugated, it is related to hepatic and extrahepatic. What issues we can find in LFT? Remember, in unconjugated hyperbilirubinemia, we find all enzymes normal, proteins normal, whereas the only bilirubin will be raised, and that too the unconjugated or the indirect bilirubin. No LFT gives you the name as unconjugated and conjugated, but it is given as indirect and direct. The unconjugated bilirubin is what is called as the indirect, and the direct is what is called as the conjugated bilirubin. So in case of hepatitis, in case of obstructive, we usually find AST, ALT and ALPR on a higher side. So what do we find in a mixed hyperbilirubinemia? We get both conjugated and unconjugated hyperbilirubinemia. So let us try to understand each one of them. So what are liver enzymes? These are basically protein enzymes which are helpful in catalyzing reactions. As I said, liver does a multitude of functions, and thus it requires a lot of number of enzymes, and few of those enzymes which can be measured in blood in case of any pathology are these enzymes. Located in different parts of hepatocytes, they are specifically present in specific parts of hepatocytes, which we understand few slides later. Degree of elevation of any enzyme, it depends on what particular damage has happened in liver. So we can group these liver enzymes into two: those enzymes which indicate hepatocellular damage and those which indicate cholestasis. So these are the liver enzymes. The one which is called as AST is also called as OT, SGOT. ALT is SGPT. I'm talking of another one called alkaline phosphatase, which is called AALP, GGT. as well as gamma glutamyl transferase, as well as 5-nucleotidase. So these are the different enzymes, and these indicate how good the liver, how bad the liver is damaged, is there any cholestasis, and all that. Moving on, let us try to understand about one group of enzymes called serum transaminases. These are enzymes. These catalyze the process called transamination between an amino acid and a keto acid. These are important in the synthesis of amino acids. These are important in the synthesis of proteins. Where are these present? These are present not only in liver, they are also present in muscles, they are also present in cardiac tissue. So what does serum transaminases say? So what are these? Let me tell you first what are these serum transaminases. The OTPT, the SGOT, SGPT, the AST and the ALT, what we commonly say, they are grouped as serum transaminases. These are the most sensitive markers of acute hepatocellular injury. You get to see a case of jaundice, 2 days jaundice, 3 days jaundice, 2 days icterus, 3 days icterus, past history of fever, pain abdomen, history of travel, get an LFT done, total bilirubin is 6, 8, 10, direct bilirubin is somewhere, if it is 10, direct bilirubin is somewhere 6, 7, higher amount of direct bilirubin, SGOT, SGPT is significantly raised in thousands. That is a, you can say, a pakka case of infective hepatitis, acute hepatitis. Normally, they are found in very low levels in serum, but in case of tissue damage, as I said, they are present in the cytoplasm of the hepatocytes. So whenever there is tissue damage, whenever there is hepatocellular damage, whenever there is hepatocellular inflammation, that is what is called, we call as hepatitis, then they are released into the blood. And thus, they become very high in blood. So their concentration increases. So what is this ALT or SGPT? It is the one which is commonly called as alanine transaminase, or it is also called as serum glutamic pyruvic transferase. And it is found in most of the body tissues, various body tissues, but it is most common in liver, which is among AST and ALT, which is more specific to the liver is the ALT. The normal level, which we commonly say it as 0 to 40. So what does high ALT signify, or does high ALT say as, high SGPT say as? So if someone asks you which is the better marker for liver damage, is it SGOT or SGPT? I mean, is it AST or ALT? We have to say it as SGPT, or we have to say it as ALT. It's common, it's raised significantly in viral hepatitis, acute hepatitis, along with other conditions like CCF, myopathies, and also in drugs. Why in CCF, why in myopathies? Please remember, this ALT is not only present in liver, it is also present in other body tissues. This is why when you get an LFT done, if there is only single rise of ALP, if there is only single rise of SGOT, SGPT with bilirubin and all other things normal, think of a non-liver pathology. Very now, obviously, when there is no rise in bilirubin, there won't be any icterus. As a routine, when we make the patient undergo these investigations, if you find only rise in enzymes, only rise in enzyme like ALP, then think of some other pathology than liver alone. So moving on to the next one, AST, or which is also called as SGOT. It is found in a good number of body tissues like liver, heart, skeletal muscle, kidney, vein, pancreas, lungs, RBC. So when you have a lone rise of SGOT, don't think of a liver pathology, please think of any of these pathology. So where is this present? It is present in hepatocytes, in the cytosol, in the cytoplasma, as well as in the mitochondria. The normal is similar to the other one, it is 0 to 40. It is raised in cases of hepatitis, acute pancreatitis, burns, MI cases is commonly raised. It is common investigations even in MI, hemolytic anemia, and lot of musculoskeletal disorders. This is why ALT or SGPT is a more specific indicator of hepatic damage than SGOT, because this is present in a good number of other body tissues, and that is present significantly lower in other body tissues in relation to liver. What is AST to ALT ratio? It is normally said as below 1.5. If it is more than 2, it says That is a case of ALD. That is a case of alcoholic liver disease, alcoholic hepatitis. Usually in cases of very early stages, it is AST is greater than ALT, which is very commonly we find. As the time progresses, it becomes reversed because of the enzyme activity. And as you find a chronic case, it again becomes as the old one, wherein AST, SGOT will be higher than SGPT as such. Moving on, this is how we have to understand um, the level of rise of transaminases. So what you have to think of, if you get a case of 3000 SGOT SGPT, if you get a case of 300 SGOT SGPT, what you have to think of. Usually in cirrhosis of liver, they can be absolutely normal. Please remember this. This is what I was saying in the beginning, that even in cases of a significant liver disease, an LFT can be normal. So one such example is this cirrhosis, because as such there is no inflammatory changes which can cause hepatocellular damage which can happen in this. So in cirrhosis, in cirrhosed liver, transaminases may be normal or very slightly raised. Chronic hepatitis, where there is no significant amount of active inflammation happening leading to cell damage and cell death, there also the level of transaminases will be in hundreds. Alcoholic hepatitis can reach thousands, whereas the one which we commonly find is a case of acute viral hepatitis, where it can range from thousands to 5,000, 6,000. And ischemic injury as well as toxic hepatitis will cause a rise of transaminases up to 10,000. Elevated serum transaminases, marked elevation, more than 15 times the upper limit. Think of viral hepatitis, think of toxic hepatitis. Moderate elevation, think of conditions like autoimmune hepatitis or chronic hepatitis or drug-induced hepatitis. Mild elevation, let us always think of non-alcoholic steatosis, and maybe a case of cholestasis, maybe a state of obstructive jaundice. This is why these transaminases are important in the differential diagnosis of hepatocellular jaundice from cholestatic jaundice. Let us all remember, these transaminases may be absolutely normal in case of massive liver necrosis also, because the necrosed liver cells are not releasing the cytosolic enzymes to the blood, and hence the AST, ALT, the SGOT, SGPT will not be high in these conditions. We go to the next one. It is called as alkaline phosphatase, the ALP. It is basically a group of enzyme which does catalyze the process of hydrolysis, and it is found in a good number of body tissues and especially in bones. So if we get a case of LFT, all values normal, only ALP is significantly raised, don't think this is a case of obstructive jaundice. This can be a case of bone pathology. So where are these ALP? Where is this alkaline phosphatase located in liver? It is in the hepatocytes. Specifically, it is located in the canalicular surface of hepatocytes. If you can see these surface here, they are located in the cells right in this area, wherein this is the canalicular surface of hepatocytes. Whenever there is damage to the canalicular, whenever there is damage to the canals, whenever there is a damage to the bile canaliculi, it ends up in release of this ALP. What causes pathological changes in the bile canaliculi? It is the obstructive jaundice. Hence, whenever there is obstructive jaundice, ALP will be raised. What is the normal value? Usually say it up to 120 is what is considered normal. So whenever there is rise in ALP, think of canalicular surface being damaged, biliary canaliculi damaged, then we have to think of the cholestatic jaundice, or it can be a case of infiltrative liver disease wherein there is damage to the hepatic sinusoids also. We should also remember one more important practical thing, that ALP, rise in ALP up to 3 to 4 times its upper limit is not very specific of any particular thing. This is why ALP is not considered a significant one if the rise is up to 3 or 4 times the upper limit. Moving on, what does a raised ALP indicate? ALP always signifies obstructive jaundice. ALP always signifies cholestatic jaundice. As we see in liver, primary biliary cirrhosis, it is not liver cirrhosis as it is the biliary cirrhosis. It is CA liver, it is cholangitis, it is obstructive jaundice. So how this happens? What happens exactly in case of cholestasis? Cholestasis causes accumulation of bile acids. These bile acids dissolve the canalicular surface of hepatocytes. Remember I said in the previous slide that ALP is present in the canalicular surface of hepatocytes. So whenever it is dissolved, there is release of this ALP, which causes significant rise in the ALP levels in blood, which results in raised ALP, which tell us that this is a case of obstructive jaundice. What are the other causes which can cause raised ALP? As I said, ALP is significantly present in different body tissues, and if only alone ALP is raised in this LFT, please do not think it is a case of obstructive or cholestatic jaundice. Can be a case of bone disorder like osteoblastic activity, as in osteomalacia, rickets, hyperparathyroidism, Paget's disease, etc., etc. So when you have to confirm is this a case of liver pathology or some other pathology, also look for GGT and 5NT. This is why, what is the significance of GGT and 5NT is along with ALP will be raised, let it be an intrahepatic cholestasis or an extrahepatic cholestasis, ALP will be significantly raised. Moving on to the next one, the gamma glutamyl transferase. It is a microsomal enzyme found in the cell membrane of other tissues also like pancreas, intestine, etc. It is significantly present in liver, in the biliary epithelial cells, in their canalicular surface. Very similar to the ALP, which is also present in the canalicular surface of hepatocytes. The raised GGT says alcoholism. What commonly we say, what is the blood test? Someone asks you, is there any blood test to identify someone is drunk? This is the one which can be utilized. It indicates alcoholism, it indicates cholestasis, it indicates hepatitis. GGT has better sensitivity than ALP in biliary tract disease because lesser amount of tissues have GGT in them, whereas ALP is found significantly in other tissues also. Alcoholism, as I said, is an important indication, which is significant to say the patient is alcoholic or not. And remember, GGT is not raised in any bone pathology. If ALP is raised, GGT is raised, think of that is a hepatic case. If single ALP is raised and GGT is normal, that goes in favor of a question mark bone pathology. Next common one is 5NT, 5-nucleotidase. It is the enzyme located along the canalicular and sinusoidal cell membrane of hepatocytes. This is very similar to ALP and GGT. When you want to confirm this is a case of hepatic source of ALP, then you have to always think of GGT and 5NT also. If ALP is raised, GGT is raised, 5NT is raised, that goes in favor of cholestatic jaundice. If alone ALP is raised, that goes in favor of some other pathology. This is useful in differentiating raised ALP from extrahepatic disorders. Moving on to the synthetic function of proteins. Let us all remember that liver is the only sole site for production of most plasma proteins, which includes albumins, which includes globulins, which includes fibrinogen, prothrombin, and others. So what are the normal values? We usually remember it as 5 to 8, 3.5 to 5, and 2.5 to 3.5. See, from protein, albumin, and globulin. Do we remember the plasma oncotic pressure? The basics behind, one of the basic point we understand behind edema. So the source of that, the one which maintains oncotic pressure is the proteins. So whenever there is a reduction in the production of these proteins due to liver pathology or due to some other loss of proteins, that will cause edema. The cause of that edema is reduction in the plasma oncotic pressure, the osmotic pressure or the oncotic pressure. That is one important function of protein. The osmosis, it maintains the fluid level in the intravascular spaces, and it attracts, literally attracts fluids to come back to uh, the blood system, the vascular system, rather than to remain outside. This does not happen when there is reduced proteins in blood, which result in increased accumulation of fluid in the extravascular tissues, which we call as edema. And these proteins are produced in liver, and they are also stored in liver. Please let us all remember this. It is also stored in liver. Whenever there is pathology of liver, whenever there is an acute pathology of liver, proteins are not hampered. Proteins are hampered, proteins become low only when there is a chronic liver disease, what we call as CLD or chronic hepatitis. Usually if it is more than 3 to 4 weeks, only then the proteins come low, because usually with acute viral hepatitis, people does not present to us with edema, wherein the chronic hepatitis cases, ALD cases, cirrhosis cases present to us with edema of the dependent part of the body, the legs, as well as collection of fluid in different parts of the body. So let us all remember this. Exclusively synthesized in liver, albumin, and it makes up 60% of total proteins. Its half-life is about 20 days. So albumin is not an indicator of acute conditions. It is not an indicator of acute hepatitis. If proteins are low, then that is not a case of acute hepatitis. If proteins are low, that is a case of chronic hepatitis. Low serum albumin always correlates with the synthetic capacity of hepatocytes. So if the serum albumin comes low, that indicates the synthetic capacity of hepatocytes are gone. That is for a good amount of time. So what can cause decreased albumin? It can be other causes also, as in case of decreased absorption, as in malabsorption. If it can be a case of undernutrition also, it can be a case of thyrotoxic or malignancy. It can be a case of nephrotic, wherein there is kidney issues, there is increased loss, or as in case of liver, wherein there is decreased synthesis, which we find in CLDs, chronic liver diseases. It is sensitive, but not very specific to liver diseases, because it has other conditions, other modes wherein there can be variation in the serum albumin. What are globulins? These are synthesized along with by the plasma cells. In cirrhosis as well as in chronic hepatitis, serum gamma globulin levels are raised, which indicate there is long-standing inflammation, which indicates there is chronic hepatitis. One important point here I would like to say is the AG ratio, the albumin globulin ratio. It is usually on a higher side. That means to say albumin is always higher than the globulin. It gets reversed in case of chronic hepatitis. Why it gets reversed? As I said previously, if you can go back to this previous slides, you can always see the serum albumin level is higher than the serum globulin level. If you divide 5 by 3, it is always greater than 1.5. Whereas what happens in case of chronic hepatitis, since the liver is not synthesizing proteins normally, since the liver is not synthesizing albumin normally, it becomes less. The level of albumin falls down. Whereas because of chronic inflammation, because of chronic hepatitis, the action of plasma cells is more. There is more and more production of the globulins. Hence, the denominator becomes higher than the numerator. That will cause reduction in the AG ratio less than 1, less than 1.5. This indicates if the AG ratio, we call it as reversed. If it has become ulta, if it has become reversed, that indicates cirrhosis. That indicates very typical of chronic hepatitis. Hope you understood. It is because of reduced albumin and increased globulin. But what is normalcy? It is higher level of albumin and lower level of globulin is always normal. We all know prothrombin is one among the clotting factors we have, and most coagulating factors, clotting factors are synthesized in liver, which are vitamin K dependent, as in factor number 2, factor number 7, factor number 9 and 10. What does prothrombin time measure? It measures 3 important clotting factors, and we all know the 2 is what is the prothrombin along with 7 and 10. So it is reduced. Prothrombin time becomes increased due to reduced production of prothrombin, as in case of hepatocellular jaundice. Whereas in obstructive jaundice also there will be prolonged prothrombin time. Why? Because in obstructive jaundice, since the bile is not reaching the intestine properly, as we all know, vitamin K is a fat soluble vitamin, A, D, E, K. We need this bile for proper utilization of this, and since the bile is not reaching the intestine, it is not absorbed in the intestine, and hence obstructive jaundice patients also end up in bleeding. Hepatocellular jaundice patients also end up in bleeding. This is where you can differentiate between hepatocellular and obstructive jaundice, wherein if a person is given a shot of vitamin K, if the person gets better with bleeding, that is a case of obstructive jaundice, because liver is functioning normally, only the bile is not reaching the intestine. That is causing a reduction in vitamin K. Whereas even if you give a shot of vitamin K and the person bleeding does not improve, that is a case of hepatocellular jaundice, because this vitamin K, whatever is given, is not being utilized because the liver is not functioning normally. So in both hepatocellular and in obstructive jaundice, the prothrombin time is prolonged. And we all know the INR and all that. So let us go back to the cases. So how does usually a case of hepatitis present to us with? It can be a history. How can we evaluate? Usually presents with a history of travel, with a contact, maybe a family member, maybe a friend have visited him, maybe there is a sexual history, maybe there is a treatment history or alcoholic history. All these patients usually present with hepatitis. Patients usually present with fever, fatigue, pain abdomen, nausea, vomiting. You have to ask people with acute hepatitis what is loss of appetite or what is nausea and all that. Whenever they have the look of food, they start getting nausea. Examination, they usually look sick, they have a tender liver and they have significant amount of icterus. Laboratory investigation usually present to us with mixed hyperbilirubinemia along with both rise in SGOT and SGPT. Usually recovers in case of hepatitis A, whereas B, C and D usually end up with complications or in case of chronic hepatitis. So what can cause hepatitis? It can be acute, as in viral toxic drugs, or also in case of autoimmune hepatitis. Moving on, this is a case study of cirrhosis. So common causes of cirrhosis we find is alcohol, and these days we are getting good number of fatty liver cases, chronic hepatitis like B and C, Wilson's disease ends up in cirrhosis. Other conditions end up in cirrhosis. Along with symptomatology, what does the symptomatology do we get in these cases of cirrhosis is we have a case of chronic jaundice. We have presentation like weight loss, we have presentation like abdominal distension, we have a presentation with nausea, loss of appetite and all that, along with edema, jaundice, ascites, palmar erythema, and all these very typical of cirrhosis. So how do we diagnose this? By, as I said, chronic cases presents with low albumin along with significant rise in bilirubin, prolonged prothrombin time, significant rise in globulins in comparison to the albumin. Radiology is an important investigation here, which guide us towards the cirrhosis, along with biopsy confirms it. These are the common presentations. We can see a case of ascites, we can see a case of full flanks, distended abdomen, and we have a case of palmar erythema, we have a case of spider angiomata, which all indicate significant rise in estrogen level, wherein the liver is not functioning normally, it is not degrading the estrogen. A small source of estrogen is also present in us, in males, through the suprarenal gland, which is usually degraded in liver. But that is not happening in case of chronic hepatitis, in case of cirrhosis. That's why that is causing these features along with testicular atrophy, along with gynecomastia and all of this. So how does a case of obstructive jaundice present to us with, they usually have a history of gallstones, a long-standing history of gallstones. Case of pain abdomen, history of weight loss. What causes obstructive jaundice is can be a case of worm, it can be a case of growth anywhere in the biliary tract or in the head of the pancreas, or it can be a case of start like this soon in case of an impacted gallstone. Usually presents with pain abdomen, intolerable itching, intolerable itching. Let us all remember, even acute hepatitis case present with itching in first 2 to 3 days or 1 to 2 days. In the early stage of hepatitis, they do present with itching because of inflammation causing functional obstruction to bile flow. Whereas here in case of obstructive jaundice, this intolerable itching continues for weeks and days together, along with weight loss. And one important feature is the pale stool. We all know this. So the signs, whereas let us all remember this, patients with hemolytic jaundice usually present with very light icterus, whereas patients with typical of hepatocellular jaundice presents with lemon yellow icterus, very bright yellow, whereas patients with chronic jaundice present with greenish yellow, as because the bilirubin gets again oxidized into biliverdin, which turns it into greenish. So how is this diagnosed? How can we diagnose it based on LFT findings? Obstructive jaundice, as we know, it is a typical of conjugated hyperbilirubinemia with significant rising ALP and GGT. Again, other investigations help us in confirming obstructive jaundice. You can see here in case of a CT, you can also go with the USG, which is commonly performed. Which is the gold standard for this is again the ERCP, the endoscopic retrograde cholangiopancreatography, which indicates, you can all see here, which indicates gallstone which is causing obstruction to the bile duct. Moving on to a case of CA liver, which is the third leading cause of death. The risk factors are hepatitis B and C virus, along with obesity, along with aflatoxins. Aflatoxin is an important mycotoxin, the fungus, the metabolic end product of fungal growth, which can happen over crops, which can happen over seeds on long storage, which is a significant cause for different CA, along with immunity issues in humans. Symptomatology usually presents with weight loss, jaundice, pain abdomen, swelling, etc., etc. One important investigation along with LFT here is the AFP, the alpha fetoprotein, along with biopsy confirms it. So let us try to interpret the previous reports I had shown. So we saw this, wherein we have a case with low HB, we have hyperbilirubinemia. We know the total bilirubin is more than 1, more than 1.2. It is a case of hyperbilirubinemia. And we have what is raised among these two is the indirect bilirubin, which is high. So it is a case of unconjugated hyperbilirubinemia. And as I said, this is a case of rise in unconjugated hyperbilirubinemia, I mean rise in unconjugated bilirubin, which go in favor of a disorder related to the spleen or RBC, which can be confirmed by low HB also. And how do you say the liver is normal? All other enzymes, proteins are also normal. So that says liver is functioning fine. Even when the patient is presenting with some kind of jaundice, that goes in favor of a prehepatic jaundice. This is usually how a case of hemolytic jaundice present to us with. What causing hemolysis, why hemolysis, what exactly is the cause of this hemolysis is another point and requires further investigations. Another LFT report which I had shown, what can we see here? There is significant amount of bilirubin is raised, and what among the two bilirubin is raised here? It is the direct bilirubin. It is the conjugated hyperbilirubinemia. And we can see a very significant rise in both OT and PT. And we have hyperbilirubinemia, we have conjugated hyperbilirubinemia, we have severe rise in transaminases, we have AST lesser than ALT, sorry, it is ALT, not ALP, and ALP and GGT are within normal limits. So this is a very typical presentation of acute hepatitis, where total bilirubin is raised, along with that conjugated bilirubin is raised. This is a case of conjugated hyperbilirubinemia, along with severe rise in OTPT, along with severe rise in AST and ALT. Please understand this as ALT. This is not ALP. This is ALT. This is sorry, very typical of acute hepatitis. We have another case wherein there is hyperbilirubinemia, there is unconjugated hyperbilirubinemia along with normal enzymes and normal HP. This is a case of Gilbert syndrome, wherein we do find total bilirubin somewhere nearby 5, which is not a significant rise with all other. These patients usually present with significant amount of sorry, not significant amount, give a history of recurrent jaundice. And how do we understand a Gilbert syndrome? Is usually they get features of jaundice, they get features of ictus, especially when they have a viral infection. That is causing more and more hemolysis, that is causing more and more release of unconjugated bilirubin into blood. There are other investigations which can feel it. We must also remember that in case of Gilbert syndrome, there won't be hemolysis because the problem is with the UDPGT enzyme here. Moving on, one more report. We have a total bilirubin 8.7 with direct bilirubin 7.1 with AST less than ALT, significant conjugated hyperbilirubinemia, severe rise in transaminases. Can we all think of what may be this case? This is a case of, again, a case of acute hepatitis. We also can see ALP and GGT are normal. We also understood that ALP, which is at least 3 to 4 times than the upper limit, is not considered to be significant. We have another case. You can see there is significant amount of bilirubin rise along with conjugated hyperbilirubinemia. You can see ALT, AST are raised, but they are not very significantly raised. Whereas there is AST greater than ALT, which indicates chronic hepatitis. Chronic hepatitis is also confirmed by the presence of low albumin and high globulin, wherein the AG ratio is reversed. This is a very typical presentation of chronic hepatitis. We have another value wherein there is bilirubin is normal, all the liver enzymes are normal, only ALP is raised. These cases you have to think of extra hepatic cause for ALP elevation, and it is not a case of hepatic cause, hepatic pathology which is causing rising ALP. So what are the other investigations we can think of in confirming diagnosis related to liver and other things are? We can also think of alpha-fetoprotein, the ferritin values, the ceruloplasmin, and other good list of investigations we have. And we do have few shortcomings. It is LFT has few shortcomings. LFT lacks sensitivity and specificity. It can be absolutely normal in case of severe liver injuries. As I said, a case of cirrhosis, a case of liver necrosis can end up in a normal LFT also, because there is no release of these enzymes into the blood because of destruction of hepatocytes. It can also be abnormal in case of patients who do not have liver pathology also. So if we try to club things together and make them into 4 points, what causes jaundice? It is because of excess production of bilirubin. It is because of impaired hepatic uptake of unconjugated bilirubin. It is because of impaired conjugation of bilirubin. Along with that, decreased excretion of conjugated bilirubin. These are the 4 main causes of jaundice, and we have a good list of causes behind each one of them, why it is causing jaundice. So to take home message, AST, ALT are 2 important markers which indicate acute hepatitis. Hyperbilirubinemia is not specific to any pathology. We have to think of other tests, group of tests under LFT to indicate what is what. Unconjugated or conjugated or mixed may give clue towards what pathology. Is it pre-hepatic, is it hepatic, or is it post-hepatic? Serum transaminases always depict hepatocellular pathology. Their level rise indicates specific illness. Think of AST, ALT, the ratio, the greater than, lesser than all. So ALP, GGT and 5NT indicate biliary tract disease and they depict cholestasis. Albumin indicates the synthetic function. Prothrombin time indicates the synthetic function. These 2 are hampered in case of chronic hepatitis. USG, CT, radiological modalities, and other blood investigations are also to be utilized for a confirmatory diagnosis if someone has a doubt for the diagnosis based on the LFT. So with these things, I uh, thank you all for giving me this opportunity to share my views on one of the common investigations performed, and I hope I've given justice for madam's efforts behind all these lot of things madam is doing. Thank you, madam. Thank you all for the patience hearing. Thank you.
बहुत बहुत धन्यवाद, बहुत ही अच्छी प्रेजेंटेशन। और मैं एक बात तो शुरुआत में कहना भूल ही गई, क्षमा प्रार्थी हूँ सभी पार्टिसिपेंट्स को कि आज डॉक्टर साहब के सन की तबीयत अच्छी नहीं है। और
No, no,
उन्होंने जब
no, ma'am.
रिक्वेस्ट किया तो मैंने सोचा चलो फटाफट ढूंढते हैं दूसरे स्पीकर, तो तुरंत ही डॉक्टर साहब ने कहा कहते नहीं मैडम मैं कर देता हूँ। और एक ही घंटा करेंगे, मगर आप देखिए कि इतना फ्लो, ऐसे में फ्लो में आप रिदम में बहुत अच्छी तरह अपना विषय का प्रेजेंटेशन कर रहे थे।
Hope I did not take too much time, ma'am.
जी जी जी। तो ऊपर ही समय हो गया और बहुत ही बढ़िया प्रेजेंटेशन। मैं समझती हूँ कि सभी पार्टिसिपेंट्स को अपने अपने जगह पर चिकित्सा कर्म करते हुए ये इंफॉर्मेशन और विद क्लिनिकल प्रेजेंटेशन और बहुत ही बढ़िया रहेगी उनके लिए। तो विश्व आयुर्वेद परिषद की ओर से आप तो परिवार के ही हैं, फिर भी
Thank
एक
you,
बार
madam.
मैं आपका बहुत बहुत धन्यवाद करती हूँ इस प्लेटफॉर्म से कि
Thank you,
आप
madam.
जैसे स्पीकर्स ने हमेशा साथ निभाया और हमेशा प्रत्येक शुक्रवार को ज्ञान यज्ञ में आहुति दी, जिसकी वजह से आज ये 10वें साल में भी अनवरत चल रही है। बहुत बहुत धन्यवाद डॉक्टर साहब।
Thank you, madam. Thank you.
जी डॉक्टर साहब क्वेश्चन एक दो ले ले अगर हो तो।
Yes, ma'am. Yes, ma'am. Please, please.
जी जी
He's doing fine now. Let us, if there are any, I can try to answer.
जी। अगर किसी को प्रश्न पूछना है तो आप अपना हैंड रेज कर सकते हैं। जी डॉक्टर साहब, अभी मुझे लगता है कि सभी को ये ज्ञान ही एंजॉय करने का मन कर रहा होगा। तो पुनश्च आपका बहुत बहुत तहे दिल से धन्यवाद। और
Thank you, madam.
जैसे लास्ट में मैं शांति मंत्र ले रही हूँ, आप सभी भी दोहराएंगे।
Thank you.
ओम सर्वे भवन्तु सुखिनः,
Kinaha,
सर्वे सन्तु
Kinaha,
निरामया, सर्वे
Sarve,
भद्राणि
Kaha,
पश्यन्तु
Shantu,
मा कश्चित् दुःखभाग्
Kashchidukkha,
भवेत्। ओम शांति शांति शांति।
Shanti.
नमो नमः। विश्व मंगल की कामना के साथ आप सभी का, सभी पार्टिसिपेंट्स का, स्पेशली आज के स्पीकर का, डॉक्टर मधुसूदन जी का बहुत बहुत धन्यवाद।
Thank you, madam. Thank you.
धन्यवाद।
आपको भी बहुत बहुत धन्यवाद.